Good morning, everyone. My name is Radwa. I did today's presentation on impetigo. So let's get started. So today we'll be talking about our patient. Um, we'll be talking about his symptoms, if he has any relative history, any physical findings, his diagnosis, and any diagnostic testing that is needed, and his treatment plan. So let's meet our patient. He is a 4-year-old male, goes by the name of TP. He is brought to the clinic accompanied by his mother with a chief complaints of facial and abdomen rash. According to his mother, the rash started 5 days ago. The rashes started as little red bumps below his nose, then rapidly spread around his mouth and chin. Upon further evaluation, his mother stated that the rashes changed in appearance to a more flattened, reddened areas with fluid-filled pustules. Um, According to his mother, he has no known allergies, he has no past medical history, no past surgical history, and is not on any medications. So let's look at his physical exam. His vitals are as follows. He is hypotensive. He's tachycardic on the monitor. He has a fever of 100.9 and he's setting 90% on room air. His general appearance, he is in no apparent distress. He appears fatigued, however, and has severe pruritus. There are reddish blisters, brown crust that can be seen on the ulcers, some pustules that have ruptured, leaving weepy red lesions and honey color crusts. Clinical presentations. There are fluid-filled bollual. Lesions are flaccid and present as the rim of thin brown crust after the rupture. There are multiple lesions that are present on the face, abdomen, and extremities. The ulcers are punched out with raised borders, and he does have enlarged axillary lymph nodes. So he is diagnosed with impetigo based on his vital signs, which he was hypotensive, he was tachycardic, and with a fever. Um, Also, he is diagnosed with impetigo based on the representation of the bumps and their location and their change in appearance, and also as his clinical presentations and signs and symptoms. If we look back at his clinical presentations, and what his mom has stated at the beginning, that the lesions have manifested initially as small fluid-filled vessels and they rapidly developed. The purulent discharge from the lesion dries to form this golden yellow crust that we have seen on the lower left picture around the chin area. And lymph nodes are enlarged. And the symptoms for it also to help us with the diagnosis is that he had severe itching, he had weakness, and a fever. So how do we diagnose impetigo? History and physical exams are essential in diagnosing impetigo. Providers diagnose impetigo generally by examining for the distinctive sores. I have provided 2 pictures of this distinctive sores that are known to impetigo in specifically, which is the picture that is on the upper right side and the lower left side of the screen. A complete blood count is often obtained as leukocytosis is common. Skin swabs for the cultures are rarely done, as it does not really aid in a diagnosis of impetigo because it does not differentiate between the bacterial infections and the colonizations. However, if the first line of treatment is unsuccessful, then the bolus fluid will be cultured in order to identify the pathogens and antimicrobial susceptibilities. Bacterial swabs should be obtained for confirmation of MRSA if MRSA is suspected in the outbreak of impetigo. Skin biopsy might be considered as well if the case is refractory. So how do we treat impetigo? With no complications, impetigo is easy to treat. Mild cases can be handled with gentle cleansing with a prescribed soap and water. The removal of the crust by soaking it in soap and water and warm water, it can really help in providing a patient with symptomatic relief. After the removal of the crust, the prescribed medication is then applied to all the cleansed lesions, well cleansed, that is. Usually, Bactroban is usually prescribed. It's a prescription strength antibiotic ointment. Mupirocin ointment is normally applied 3 times a day. And for more severe treatment, oral antibiotics will be provided, such as clindamycin or the penicillin family. Like I said, for severe cases, the patient might require oral antibiotics. Antimicrobial treatments is indicated to relieve symptoms, prevent more formation of the lesions, and prevent complications, such as cellulitis. Antibiotics, whether it's for topical or systematic coverage, it decreases the duration of the illness and the spread of the lesions. Most importantly, they decrease the chances of complications involving the patient joints, bones, kidneys, or lungs. With proper treatment, healing of the skin lesions generally is rapid and occurs without residual scarring. Providers must also inform patients and their caregivers that impetigo is indeed a contagious condition and is spread by direct contact with someone who has it and within a close proximity. Therefore, close contacts may need to be also evaluated or must be cautious to not spread the infection to the rest of the family. Caregivers should also be advised of the importance of not spreading the infection to any other parts of the child's body. The most important measure of prevention is, of course, frequent proper hand washing. Patients as well as others should be cognizant of not touching the rashes. The clinical response should be seen within 7 days of initiating the antimicrobial therapy. And those are my references. Thank you so much for listening to my presentation. I hope you enjoyed it and learned a lot. Thank you so much.